Right, so let's look at how do we evaluate an optic nerve, what is DDLS, that is disc damage likelihood scales, and what masquerades we look at. Definitely need intraocular pressure and the disc changes and field effect in addition to gonioscopy. But why optic disc is most important, because this is something which is very specific in diagnosis. The intraocular pressure and visual fields can lack sensitivity, there can be an overlap, and the anatomical changes definitely happen earlier than the functional changes, and that's how we need to look at it. So we definitely have to learn how to carefully examine a disc and understand what is the proper examination technique, so that we can understand what is the normal appearance of the disc in NFL, what are the changes in early or pre-perimetric glaucoma. So we should be able to diagnose glaucoma, like how on the upper disc that you can see there is a loss of inferior rim rather than the lower stage, because we don't want, this is that the lower diagram that you see is very evident advanced glaucoma. So the best way to look at the optic nerve is not really the indirect ophthalmoscope or direct ophthalmoscope, because direct ophthalmoscope does not give you a stereoscopic view, and the indirect ophthalmoscope gives you a very less magnification. How to play the video? Okay. Right, so this is how we actually do the optic nerve evaluation on a slit lamp biomicroscopy. So it's important to understand how do we do it. You position the patient properly on the slit lamp, taking care that the line matches the nerve, the center of the cornea, and with the undilated pupil on a retroillumination, you go close to the cornea and then focus on the cornea and then interpose the lens and try to pull joysticks toward you, and that is what you see. You can see in the bottom square that this is how the optic nerve looks like. So all of us as glaucoma people should look at the undilated disc before we do the gonioscopy, so that we have an idea of how the optic nerve looks like. And when eventually after dilation, it is important to look at the optic nerve too, because the NFL defects or a small disc hemorrhage is something that you can miss if you have not dilated the pupil and evaluated the optic nerve. Now, so we know this is how we look at, and now I will be taking you through the different features in glaucoma, and we will be talking about each one of these topics. So these are the different list of optic disc changes that you see in glaucoma, that is loss of eye-ascenti pattern, disc hemorrhage, and different effects. I'm not going to read through that. The basic thing that I want you to understand is there are certain objective signs, that means say presence or absence of a disc hemorrhage or presence of a NFL defect or notch, etc. And there are certain subjective signs where the CD ratio is this much, or there is asymmetry and things like that. So objective signs are something that we cannot ignore, because they are very specific of glaucoma. Subjective signs can vary between you and me, or two colleagues where we are examining. So we have to be sure and substantiate them with the various investigations. Now coming to the optic disc size, the variability in the optic disc size varies as high as say 0.8 millimeter square to 6 millimeter square, and that is independent of any other refractive errors and stuff. So you can have a small disc with abnormal cup being 0.5 and a large disc with 0.7, 0.8 cup being normal. The size increases with high myopia and lesser with the high hyperopia, and there is a ethnic variation, racial variation that we need to keep in mind. There are certain disorders that happen in smaller discs more commonly and the larger discs more commonly, that are listed here. So is it important to do the optic disc size measurement? Well, not in all cases, but where you find that there is an asymmetry between the two eyes, or if you want to really look at, then you can use a slit lamp biomicroscope with a thin slit, so that you avoid the spillover, and you can use any of the lenses and have the multiplication factor. However, if you keep using the same lens throughout, you can actually have an idea of whether it is small, medium or large disc, which is important to understand when we talk about the CD ratio and all. So coming to the CD ratio, this is the most common thing that we document when we see that CD is 0.5, CD is 0.3. That is why, because this is something which you can follow up over a period of time. So what is the disc margin? That is the defined by the inner edge of the white scleral ring through which the nerve fibers pass or ganglion cell pass. The cup is the level where the neuroretinal rim steepens. So that is the CT ratio, and what we talk about always is a vertical CD ratio, not the horizontal CD ratio. This is a C by D. So CD ratio can be normal as low as 0 and as high as 0.87. So we need to understand when we are talking about CD ratio that what other things we need to look at. Generally speaking, more than 0.6 is considered abnormal or doubtful of glaucoma, because that is seen in less than 5% of the patients, and the 0.2 asymmetry between the two eyes is also something which is seen in less than 5% of the normals. So we have to be careful when we have this kind of CD ratio. So what is the importance of this CD ratio? Well, we know if the disc size is bigger, the number of axons that has to pass through that canal is the same. So cup is something which is a leftover space. So if you have a larger disc, you are bound to have a larger cup. If you have a smaller disc, you're bound to have a smaller cup. So that is why CDR does not mean anything unless we specify whether it is a smaller disc, medium-sized disc, or a large disc. So that is how CD ratio becomes important. So more importantly, over a period of time, when you see the higher CD ratio, that suggests progression. If you see asymmetry between the two eyes, that gives you an important clue. And in general, high CD ratio gives you a suspicion of glaucoma so that you can evaluate more carefully. So this is the progression. Upper one is the progression over a period of time, and the lower one is the right and left asymmetry. So this clinical example that you can see, the right eye on the top and the left eye at the bottom, CD is much different, 0.3 up and 0.6 down. And if you look at the visual fields there, you can see the superior defect in the left eye, which clearly tells you that that is glaucomatous. Coming to the neuroretinal rim, well, this is the most important part, because that is where the ganglion cells lie, and that is what we are interested in. We don't want the loss of NFL or neuroretinal rim, so that has to be evaluated clearly, carefully. So there is a IS&T rule, I'm sure all of you are aware, which says that inferior rim is bigger than the superior, and then the nasal and the temporal, so you have to keep that in mind. This particular rule is less marked in larger disc, because the nerve fiber layer or a neuroretinal rim is more evenly distributed, because the ganglion cell axons pass towards the periphery. So this rule applies largely to the medium-sized disc. The smaller disc and larger disc, you can ignore that. Coming to the shape of the neuroretinal rim, now if you take a cut section of the optic nerve, the first thing that you see, the normal, if you see a cut section, you will see a horizontal cut there, the neuroretinal rim. This is how the shape of the neuroretinal rim should be. When it bends like that, and the second, I'm sorry, I'm not able to see my mouse on my screen. Yeah. So this is where it becomes sloping. Okay, so that is what is called as saucerization of the disc. And in the C diagram that you see, there is a loss of differentiation between the neuroretinal rim and the cup, and that is called as sloping. And when you have the excavation, that is when you see a notch. These are the diagrams, and this are the real clinical pictures of the same discs that I demonstrated to you. So when we see in stereoscopic view, you can actually see which category it fits into. So this is a clinical example of a large disc where you see the CD ratio being very high, but if you notice, inferior rim is less than superior rim, so we are having a loss or reversal of the IS&T rule, and that's what is shown on the perimetry also. You see a superior defect corresponding to the thin inferior rim. So in this particular example, there was loss of IS&T, there was increase in the CD ratio. That's how we picked up glaucoma. If you see a notch, like how you saw the excavation in the fourth diagram, you can see a corresponding field defect there. Disc hemorrhage is again a very specific objective sign. Presence of disc hemorrhage definitely means glaucoma, because it is seen in less than 1% of the normals. However, absence of disc hemorrhage does not mean much, because it is seen only in, say, around 5% of the glaucoma patients, because it does not last long. It lasts for a few weeks, and eventually it translates into a nerve fiber layer defect. So even when you are seeing the patient during that time when the disc hemorrhage happens, then only you will be able to pick it up. So it has a low sensitivity, but very, very specific for glaucoma. Like this example, you can see a small disc hemorrhage, and you can see a corresponding field defect also. Circumlinear vessels, another important thing that you can pay attention to. Well, all of us do not have circumlinear vessels. Only 50% of us have circumlinear vessels, and they look like this. They exit from the neuroretinal rim and exit at the macula. They follow the neuroretinal rim. So people who have circumlinear vessels, in them, when there is a loss of neuroretinal rim, which is called baring of neuroretinal rim, that is suggestive of glaucoma. Again, one of the very specific signs of glaucoma, but mind you, all of us do not have circumlinear vessels, so we should look for it. Another very important sign for glaucoma or early glaucoma is a localized NFL defect. Now these are the wedge-shaped defects that you see coming from the optic nerve and then fanning out towards the temporal raphe. They are dark areas where the nerve fiber layer is gone, and they are very, very specific for glaucoma. You can see an example where here you can see superior and inferior NFL defects and the corresponding visual field defect, superior and inferior, as you can see. The best way to examine an RNFL defect is green light or red-free photograph or a red-free filter when you're seeing on slit lamp, because they become prominent like that. Well, there are ways to check it in terms of imaging techniques, OCT, HRT or GDX, but here we are talking about the clinical evaluation. So a red-free diagram makes it much more prominent. So this is how a normal NFL looks like. The normal nerve fiber layer obscures the normal vessels. You see very limited slit or groove-like defects, which are narrower than the retinal vessels. When you look at the localized RNFL defects, they are actually large, dark wedges, which are larger than vessels. They are narrower at the disc margin and then become broad. When there is a generalized NFL defect, you see the loss of that dark, bright pattern which you see in the normal NFL. So this can happen in advanced glaucoma, AION, and any situation where there is a generalized NFL loss. Peripapillary atrophy is something which is a corroboratory sign, which is not a definite sign, but that helps a lot if you look at the central beta zone and peripheral alpha zone. In glaucoma, we will be talking about mainly the beta zone, because alpha zone is seen in almost 95% of normal people also and is related to myopia and age as well. So beta zone is more important and is larger in high myopia or myopic glaucoma. The problems with myopia and glaucoma is that sometimes it is hard to see even the disc margin, so it's very difficult to assess the neuroretinal rim, to assess the CD ratios. So in these situations, we largely have to depend on the functional aspect or the perimetry, because it becomes difficult to judge. Just to give you an example where the perimetry can also give you a doubt and you have to be careful. So this is a patient who has myopia, and you can see the field effect in the left eye, but be careful, this is not the glaucoma, this is the enlargement of blind spot which is related to the myopia and peripapillary atrophy. Why I do say that peripapillary atrophy is a corroboratory sign and not a definite sign. Now this is a classical example of that disc. If you see the PPCRA or atrophy is much more inferior, but if you look at the disc, the neuroretinal rim is much thinner, superior. And you see a field effect which is corresponding to that superior thinning and not to the peripapillary chorioretinal atrophy. So what does that mean? That means we should not get biased only by the large peripapillary atrophy in one direction. We should look at the neuroretinal rim in terms of glaucoma. Now coming to disc damage likelihood scale, I'm sure all of you are aware of this thing. Just to give you a brief of what things it takes into account, what we all went through during this presentation is something, it is a summary of that almost. That is the disc size measurement it takes into account. It takes into account the neuroretinal rim thickness. So it looks at radial width of the neuroretinal rim at its thinnest point. And that is the rim disc ratio that we look at. It does not take into account CD ratio. It takes into account rim disc ratio at a thinnest point. Okay? And when there is no rim, it is considered to be a 0. And it also takes into account that what is the circumferential extent of the rim absence. What we need to be cautious about it does not tell you about the sloping or the absence of, if there is a total absence of the rim, it does not take into account. So the number 1, 2, 4 is considered disc at risk. 5, 6, 7 is considered glaucomatous damage, and 7, 8, 9 is considered glaucoma disability. Just an example, this is the nerve that you look at. Now look at, this is a large disc. It's the thinnest rim width is there, the blue line that you can see. And if you look at disc diameter in that axis, you see the rim disc ratio say around 0.15. So this is where it fits into the DLS stage 3. So what is that? That is supposed to be disc at risk. Another example, you can clearly see a notch there. This is a medium-sized disc, so no rim at that place. Circumferential extent of rim absence is around say 45 degrees. And this fits into DDLS stage 6. So this is the glaucomatous damage. And this is an advanced damage. You can make out no rim. almost 240 degrees, there is circumferential extent of rim absence. So this fits into stage 9. So this is a glaucomatous disability. So that is how DDLS helps. But believe me, the best way to document is disc photographs. And the next best is the hand drawing that you make in your chart about how much is the absence of the rim, where is the slope, where is the notch. So that is the best way to document. There can be pseudo glaucomatous discs, which I will not talk much about. Dr. Jyoti will take you through. And always remember that we have to look for glaucomatous changes in all the discs. We have to look for RNFL defects in all the discs. We have to look for disc hemorrhages, and we should consider each myope as a glaucomatous disc so as to evaluate them clearly. So these are Jost-Jonas rules. Just to give you a clinical example, this is a 41-year-old male, and you can see an NFL defect down there. Everything else was normal, not suggestive of glaucoma anywhere. You do a visual field defect, there is nothing, but when you do an OCT, you can see a corresponding thinning there. So in this situation, it is the only careful disc evaluation that could make us diagnose glaucoma and treat this patient, because when we did DVT, the pressures were high and we started on treatment. And later on, when we did the blue on yellow field, it actually showed defect in that part. I think that is missing here. Another situation where there's a patient who was having glaucoma and on glaucoma treatment, and this is the field that he came along with. But when we looked at the optic nerve, it looked perfectly healthy, and you could substantiate it by OCT. So unless you have a careful disc evaluation and you treat only on the basis of perimetry, that's not going to work. So this was just a clover leaf defect and unreliable fields. So unless you do a clinical evaluation, you can actually have an unnecessary treatment for any patient. So fields could be deceptive, but not the disc evaluation. I think I will skip this part.
You can take it, Sushma.
Huh?
You can take the case.
Is it? Okay. So this is a classical example where everything correlates. We don't get such nice cases every time, but here you can see a 30-year-old male presenting with 18 pressures. You can have you had superior rim thinning and superior notch in both the cases, and you could see the visual field defect there, both inferior defects there, and OCT again corresponding. So everything matched, POG on treatment. This is the simplest way to diagnose, but then there are crucial situations, as I showed you in the earlier cases, where the clinical skills help, and we need to definitely look at it more carefully. So always identify the clinical signs, and interpretation of the various tests should be done in light of the clinical signs, and connecting the dots is most important before you label a patient and start treatment. Thank you for your kind attention.